Okay, I'm going to hand things over to Doug and Heather.
Thanks so much, Patrick. And this is a fantastic turnout. Thank you, everybody, for joining. As Patrick mentioned, I am Doug Golub, and we're here today to talk about our data outcome stories that we do for Metasced. This one focused on complex, high acuity populations through care management and application of data analysis from a process that integrates care management and technology to improve individual well-being and performance. And with me is Heather Barr.
Hello, everyone.
Heather. All right. So this graphic on the left here, it looks like you're in need of some managed care. I don't know how many physicians are actually saying that, but for the purpose of today, we're going to focus on some of the opportunities that are available with care management, especially for complex populations, where it's necessary and helpful to bring in the individual, the family, the community, the population, as we look from health to disease at a population level, biological factors, behavioral, social, and environmental. It's not one thing, it's everything. And understanding these populations and understanding the opportunity for managed care is clear for a lot of the policy that takes place. Today, we also look at some of the data. We've been researching for this presentation for about 2 years, and we've just wrapped up a study over a 2-year period that hopefully helps us with some of the trends and opportunities that we've identified in some of the data that we were having trouble finding out there until we took a look into the populations ourselves using tools that were available to Metasced. So understanding the roadmap of managed care and home and community-based services and long-term services and supports. We're going to start this journey in 1973 with the Health Maintenance Organization Act from Congress, which is probably one of the first recognizable forms of what today we know as managed care. 10 years later, home and community-based services becoming available in 1983 when Congress added Section 1915C to the Social Security Act, basically creating what we know today as Medicaid waivers. And when we look from 2004 to 2021, how we've integrated managed care with long-term services and supports and home and community-based services, we find that just 8 states had integrated these in a capitated way together in 2004. Today, or at least in 2021, that's 24 states. So there's been some big movement, certainly since 1973, but also since 2004. Today, and the population that we focus on today here with MHPA, there are 8.8 million Medicaid beneficiaries receiving long-term services and supports, at least in 2019. And of those, about 19% are receiving institutional services. About 84.3% or 7.4 million people receive home and community-based services, and about 3.3% receive both. So there's about 7.7 million people receiving today home and community-based services, fee-for-service, long-term services and supports that we're looking at for the universe of this population that is covered under managed care or can be covered under managed care, where sometimes these complex populations don't necessarily have the focus or the specialty. Today, we aim to do that because that's the primary work that we do here at Metasced. When we say complex populations, when we talk about whole person health, these are generally the 8 cohorts of individuals that we're speaking of: aging with disabilities, children with disabilities, HIV and AIDS, intellectual and developmental disabilities, mental and behavioral health, physical disabilities, and traumatic brain injury and spinal cord injuries. These are, for the purpose of today's conversation, what we're referring to as the complex populations that we study. When we think about whole person health, we talk about bringing together and decoupling some of those, or coupling some of those disparate elements of care: the physical health, the medical model, the social supports, the home and community-based services, the mental, the behavioral health. It's not one thing, it's everything. And bringing that all together in managed care helps provide opportunities for individuals and their circles of supports to improve outcomes at the individual level and also at the population level.
All right, so before we talk about what makes whole person health complex for these populations, we should address our photo on the screen. We had some stock art with a person that we didn't know. And so we thought, you know what, this is going to make it more engaging if we just do the photo ourselves. So here, filling up the white space is me posing. So thank you for entertaining us a little bit. So whole person health for a complex population, many individuals have multiple chronic needs and behavioral health needs that are not their primary diagnosis. Many are on multiple medications for things like depression or seizures, and each of these can lead to side effects, things like weight gain that ultimately could potentially lead to diabetes, hyperlipidemia. So there's many layers to consider here with managing, health and pharmaceutical needs. Disability is lifelong. Individuals need support to nurture a full life for their whole life. And as their wants and needs change, as they age and their abilities change, the things that they need to support them is going to change along with that. Many have communication and cognitive challenges. This affects decision-making, choices. It affects the ability to communicate pain and illness, and frankly, makes folks more vulnerable to abuse and exploitation. So you need an extra set of eyes to monitor and make sure that everything that's going on in their life, and the people in a complex person's life are really supporting them. Speaking of that support, dependency on caregivers is huge. So that once you have additional people, you have additional supervision and oversight that you have to have. And then if we think about folks who live in a congregate setting, there are additional challenges with independence, maybe even higher rates of abuse and neglect. So again, that additional, monitoring of, everyone who's coming in and out of this person's life is really beneficial. Physical health challenges for complex folks. When you have a physical health challenge, getting up and moving and making social connections can require a little more effort. And without those social connections, you can see an increase in loneliness. And if loneliness gets to the point of depression, there are additional complications that Doug's going to talk about in a few slides. So there's just really, complex folks are, they're complex. So if we go to the next slide, we're going to talk about some prevalent trends that are, somewhat unique to complex populations. So our first item on this list is the Fatal Five. And the Fatal Five this refers to the top 5 disorders that are linked to preventable deaths of individuals in a congregate care setting or in a community-based residential setting. These would include bowel obstruction, infection, aspiration, dehydration, and seizures. And these are different in a complex population than what may be in a non-complex population driving to preventable deaths of something like pneumonia. So this is something that is unique that needs to be monitored for, especially when folks present at the emergency department. And speaking of the emergency department, that's going to be more prevalent, again, in this complex population because more than 1 in 4 individuals were hospitalized in the year prior to referral to a community-based crisis intervention program. Hospitalizations are just going to be more common. And the other piece is that mortality rates are higher in this group. Life expectancy is lower. So all of this contributes to a multi-layered lens of management for folks in this population.
This being MHPA, we look at complex populations and how they're supported by Medicaid in various ways across different states, across different programs. And so depending on the type of disability, the diagnosis, depending on what's available in that state, people will be enrolled in dual eligible special need plans or DSNPs, I-SNPs, C-SNPs, Medicare, Medicaid plans, fully integrated dual advantage plans or FIDAs, behavioral health care management, long-term services and supports or managed long-term services and supports plans, primary care case management, or other types of managed care. They could also be enrolled in fee-for-service plans if that state is not one of the 24 that we mentioned earlier, or the program that the person's on is not in one of those states from their cohort of diagnosis. And so depending on the person, depending on the state, there are different options. So today we take a look at different options that are available for people. And again, it depends on where they live and their own eligibility criteria. Medicaid's Care Coordination Suite are the tools that we used to help illuminate opportunities to improve outcomes by looking at claims data and also electronic health records data. We used Metasced's tools because we are from Metasced and those are the tools that we have access to. However, a lot of the research that we've done and the findings that we've had could be done many, many different ways. We just did it this way because that's where we come from. So we'll be looking at some opportunities with fully capitated or coordinated care versus some fee-for-service or disparate silos of care to see what lessons we could find, what opportunities there are, what data outcomes there are for certain key areas today: ED visits and hospitalizations, depression and anxiety, breast health, diabetes management, access to preventative care, body mass index, and we'll be looking at cost of care, some of the financial outcomes. When you look at published articles about managed care, many take you to the financial areas. We wanted to contribute in a way that did some studying on other outcomes aside from just financial, although there are financial outcomes in this talk today as well. To describe the population, today we studied 2,730 individuals across the US. They all have the following attributes in common. They all have 2 or more chronic conditions. Everyone is over 21 years old. Everyone is Medicaid waiver enrolled. Everyone lives in a community setting that's either certified or non-certified or an intermediate care facility. And we have over 2 years of administrative and claims data plus Metasced care management electronic health record data available for each of these 2,730 people. Of the 2,730 people, about 40% are enrolled in Partners Health Plan. Partners Health Plan is a fully integrated dual advantage, or a FIDA, IDD. They're based in New York, and they are the only fully capitated physical health and Medicaid waiver and IDD plan in the United States. So Partners Health Plan is extremely unique. However, they can help us with some very big opportunities because of how they've been able to pull together disparate systems of care under a fully capitated care management model. Also, about 60% of the people that we study, they are not in a fully capitated managed care plan. They're enrolled in other fee-for-service plans and or straight Medicaid for components of their service. They don't yet have care management. Some may, some may never. But Medicaid has the claims data, and there is no care manager for about 60% of the people that we study today. So when we are looking at the cohorts, it's very helpful to take a look at the difference about what is the promise of managed care, what is the promise of fee-for-service, and how can we use that in decision-making and thought to improve outcomes, both physical health, social, and behavioral, and financial to the organizations for everyone. In addition, we have some stories of people, and the people's names have been changed, the details have been masked, but these people all come from electronic health records. Typically, one of the ways that we find a lot of these people is by looking at some of the highest cost individuals or some of the highest visits to the ED, and that helps on the dashboard to identify people. And then we look at their claims and we look at their stories and we read some of their notes that are available through the Metasced platforms. That helps us understand a little bit of the story, that helps us also look at some of the measures and color those measures a little bit more without physically meeting the person. So here's a person who's 66. Her name is Zelda. She loves going to her family cookouts. She loves 70s music. She likes shopping with her niece. She likes playing chess on Thursdays in the park. She lives on her own and wants to continue living on her own, but she gets sick a lot, and she's not sure if she would be safe somewhere else. She struggles to stay in bed. She has urinary tract infections, insomnia, and gastrointestinal issues. She's been taken to the ED 6 times, almost once every other month in 2021, which is a lot for Zelda. It's a lot for anyone. And this is helpful for us to try to identify if she were to move into a care management setting, or if she happened to be in a care management environment, what would be different? What could be different? And so with that, Heather is going to walk us through.
So wonderful. So some recommendations to help Zelda avoid the ED. We could potentially investigate possible diet adjustments to decrease her gastrointestinal distress or UTIs and insomnia associated with pain. Personal care supports would be helpful, potentially to teach her about some self-monitoring for UTIs, like the urine dipstick test. Zelda has been offered some new living situations, but she's worried that she's going to miss her family. She wants to continue to live with independence, but also close to them. And a care manager can help her find in-home supports that could meet this criteria to help her stay at home and be safe and to teach some of these self-care routines. And we should explore some personal care monitoring technology for her as well.
Thanks. So as we go through each of these areas, there are some stories mixed in. There's also some data mixed in. And so we're going to start by taking a look at ED visits and hospitalizations. Reducing hospitalization rates, that's key to controlling healthcare costs, and also resulting conditions and issues for complex populations, as we've defined a complex population today, or 8 of them. Complex populations, they are admitted at far higher rates than the general population due to factors including their health, their lack of awareness of the provider, lack of awareness of their disability. And as we've had a chance to look, the general admission rate is somewhere between 10 and 15%, but for some of these complex populations, the admission rates could be as high as 40% because those hospital providers don't necessarily have enough information about the type of disability or awareness, and they are concerned about the risk of a discharge. There are some tools that are available in care management. For example, regional health information organizations, RIOs, or health information exchanges, HIEs, have the ability with consent, depending on the state, to be able to share admission, discharge, and transfers to the care managers to help inform in real time that there's been an ED visit and or a hospitalization, and the alert right away is available. Frequent visit trends and taking a look and doing rounds, as certain managed care plans do, can help care managers implement whole person supports and interventions to prevent some of these crises from occurring. There are other opportunities for people that may be frequent visitors to the ED, other social supports, other housing opportunities, other health opportunities, urgent care settings, and beyond that might end up better for the person and also from a cost perspective as well. And preventable readmissions through appropriate discharge planning and the tools available to a care manager to even have visibility into any of this are helpful. We took a look at managed care populations. We paused looking in 2020 because with COVID-19 that became 2 variables and we didn't want to commingle two different things. But studying the managed care trends for the admits per 1,000, as you could see, it was lower than a fee-for-service population and decreasing. And the trend has continued on this trajectory. COVID-19 seemed to decrease a lot faster, but we chose not to commingle 2 different things there. So there is the opportunity for care management to help with fewer ED visits, fewer hospitalizations, better discharge planning, better readmission, preventable readmission rates. Next, we look at depression and anxiety. And depression can co-occur with other serious medical illnesses such as diabetes, cancer, heart disease, and Parkinson's. Of course it can. But these conditions are often worse when depression is present, and research suggests that people who have depression and another medical illness tend to have more severe symptoms of both illnesses. Here's some data from the CDC. This is national data. This is not our study. That's next. That shows some of the comorbidities for people with depression, for people with disabilities. And what we see in each of these, whether it's heart disease, diabetes, smoking, obesity, we find that these rates are higher, almost double, as you can see in many of these measures, for people with disabilities than for people without disabilities. And we know that there's a multiplying effect. So when looking and supporting a complex population with disabilities, this is helpful to know that these concerns are magnified. And addressing and identifying depression and anxiety is important for whole person supports. There are plenty of tools out there. And so some of the tools that we've been able to look at, specifically in our fee-for-service population, to identify what would be possible, especially with managed care in the mix, as we've used the general anxiety disorder, or the GAD assessment, and the patient health questionnaire, or the PHQ. And in those, simply by looking at some assessment data, we've been able to positively identify in the GAD2, 10%, and the GAD7, 9% of fee-for-service members. What that means is there's a need there that is appearing, and that need requires an intervention or many interventions. It's identified in an assessment, needs to make its way into a service plan. With care management, that seamless process can happen. Without care management, this is disparate. We've also identified from the patient health questionnaire, this identifies the frequency of depressed mood over the past 2 weeks. About 8% of people positively screening at a level where an intervention is recommended. And for the most severe depression, positive screening in 5% of those members. 2.6% of members required further assessment for suicide risk. We're working with behavioral health populations, working with aging populations, intellectual and developmental disabilities populations, physical disabilities populations. These assessments are ringing a loud warning bell, and through appropriate care management, connecting people to supports, addressing these needs are critical, because what happens when these needs are not addressed is not in the interest of the person, nor is it in the interest of the health plan. Being able to consistently assess and identify and act upon it is one of the biggest opportunities with managed care. So we'll tell another story here. This is Danica. She's 56. She enjoys making cards and caring for her cat, Mickey. She still lives in her childhood home with her elderly parents. She ran track in high school. She continues going for jogs. She's living with schizoaffective disorder, and she experiences severe reactions to stress. And when she's stressed and not under supervision, she will wander. She also likes to go for jogs, and she's been hit multiple times by cars. And these unfortunately come from the actual stories in the case notes for people. She doesn't necessarily understand the rules of the road. She's been injured while she's been out. She showed up on our dashboards because she's been to the ED 8 times in 2021. And there's an opportunity for care management intervention here to help suggest some opportunities to make sure that Danica is managing her behavioral health diagnoses, managing her physical health, managing her safety, and hopefully enjoying her interests, which are making cards, her cat, etc. And so with that, we're going to talk about some options that are available to someone like Danica.
So what we saw in the care manager notes in our system is we saw some questions about potentially changing her living situation to see if her elderly parents were still able to offer her the supervision that she needed. And we saw some activities toward determining the suitability of housing arrangements. We also think about guidance and teaching for protection for her when she's outside running. There could be an opportunity to place reflective clothing right by the door, so it's right there when she's ready to go outside for a run. She could find a running buddy and someone to go with her and help her navigate sidewalks and stop signs and crosswalks, all of that to keep her safe. There's another opportunity for potentially structured exercise environments, so like a YMCA or community center close to home. And additional notes, we found encouragement for her to make a card making business and start showing at craft shows to help encourage her with her individual direction. All right, and I think, Patrick, we are ready for our first poll.
Yep, indeed. Okay, here we go. All right, folks.
All right,
so our next section is on breast health, and this poll is sort of asking you, before we get into it, since you haven't seen the slides yet, what was the 2019 Medicaid HMO HEDIS average score for mammograms across Medicaid health plans across the United States in 2019? Was it 79%, 58.4%, 33.7%, and 6%? And I should mention, this is women between the age of 50 and 74, for which the HEDIS measures that mammogram over a 2-year average.
All right, we still got some time left if you want to answer.
We're going to test your HEDIS knowledge here.
There you go. All right, a couple more seconds, then I'll go ahead and end it and we'll share. Okay, last chance. Here are the results.
Ooh, good guesses. Good guesses, everyone. All right. So the answer's on the next slide here. So the answer is our blue dot there in the middle. It's 58.4%. So a number of you got it right. Breast cancer screening is obviously quite important. So women diagnosed with breast cancer who had regular mammograms have a 60% lower risk of dying of the disease in 10 years after diagnosis compared to women who do not have a regular screening. So as you can see from our additional dots, the gold dot shows that folks in the managed care population actually had a higher rate of getting their breast cancer screening, while the fee-for-service group who didn't have a care manager only had 6% rate of getting their breast cancer screenings. So the advantage here of managed care is quite obvious. And as you can see here, there's on the right-hand side, there's a screenshot for just a quick reminder for a care manager just to say, hey, we need to arrange a breast cancer screening. Maybe it's for Danica in the last story, just to try to keep, tabs on folks and make sure that they're getting their care. And what I do want to point out about the managed care population in this particular story is that, again, this is Partners Health, and they've been an advocate for the use of alternatives to mammography. So for those of us who have had annual mammograms, and we can tell you that the standard issue mammography unit is not the most accessible piece of equipment in the world. And so having a sonogram, which can come to you, if you're sitting in a chair, have this be approved by state Medicaid for a quality measure for breast cancer screening is huge in increasing the accessibility of breast cancer screening. All right, so our next topic we're going to review is diabetes management. So diabetes A1C screening in the general population is something that most everyone needs to do, or most primary care providers do. It's just part of the annual blood test as part of your wellness visit. And we know that 13% of US adults have diabetes, but we do also know that folks with disabilities are more likely to develop it. And in our sample, 25% of members had diabetes, which is close to double the national average. And then again, the advantages of managed care are quite obvious in our gold dots on the right. The left-hand side shows screening for the A1C screening that's used to diagnose diabetes. So just a standard regular annual screening. For fee-for-service group was only 13% folks were getting screened, whereas in the managed care group, 65% were getting screened. But then among folks who were diagnosed for diabetes, 28% in the fee-for-service group were being actively monitored, whereas 83% in the managed care group were being actively monitored through checking the A1C every 6 months as the guidance suggests. All right, and next topic is access to preventive care. Again, we see a difference, maybe not quite as strong this time, but periodic wellness visits to help establish a health baseline and keep up on preventative screening, educate members about chronic disease risk, build a relationship with primary care physician. Again, we're talking about complex folks. So one small change over time can really mean a lot in how care is managed, and keeping that constant touch base with the provider is really, really important. Among our managed care population, we saw that 90% of the population was getting these regular screenings, whereas only 75% of the fee-for-service folks were getting the same. Again, not a huge difference, but small differences make a big difference when you're in a complex group. We have some screenshots here from our system of, again, just some outreach tracking, reminders, let's get that preventative screening. And then as what obviously came up during the pandemic, we needed to have options for telehealth. And so we did start to track how many of these visits were happening, over the telephone. Was it a video conference visit, to try to keep that connection between the patient and their, provider, even though it wasn't as safe to go out in public during that time. So then we have some data to show that there was certainly a spike. It's what we would have expected. So we saw a spike in 2020, up to 67% of visits for telehealth. Then we are starting to see, a normalization is coming down a little bit, but we don't expect it to go to zero. There's just so many benefits to telemedicine for persons with disability. I mean, there's a lower cost of care, lower transportation costs, improved medication reconciliation, less exposure to communicable diseases, especially during a pandemic, and a decreased need for paid personal assistant services to help you, navigate the visit, navigate, the provider's office and transportation to and from. All right, I think this is our last story. We're talking about Adam. He's 34. Adam likes to go to movies and especially enjoys Marvel movie marathons. He will buy $1,000 worth of movies on Amazon if his internet access is not monitored. He does want to have a girlfriend, but he gets anxious talking to girls. He lives with his great aunt Cindy, and he is a person with cerebral palsy. He has needed to go to the ED multiple times in 2021, up to 14 visits due to falls.
And so 14 visits definitely shows up on a frequent ED list. And that's what had us start to investigate Adam and his story and try to understand how care management could help. And so some of the recommendations, we're taking a look at where Adam lives for accessibility and suitability. Are there railings or ramps or environmental modifications that can help with safety? Is there assistive technology or durable medical equipment that can help avoid unnecessary trips and falls? Is it time to have conversations with Adam and his great aunt Cindy to look at other options for both of them that might help with safety? And it's really up to Adam and Aunt Cindy, but are they educated on all their options? And of course, encouraging Adam to join a movie enthusiast club so that he can meet people and hopefully find a girlfriend or find friends, or just make sure that he is living a life that brings him joy and interest and purpose. Next up, we're going to take a look at BMI, body mass index. And so obesity increases the risk of several debilitating and deadly diseases, including diabetes, heart disease, and some cancers. And what we've done by studying almost 3,000 people is taken a look at the BMI assessments for people and identifying, based on living situation, if there are any trends. And we found a trend, but it wasn't what we were hoping to find. What we found is that people that live in the most integrated settings, in an apartment by themselves, with family, with friends, in a non-certified setting, had some of the highest rates of being obese and overweight, more than half. However, people living in certified settings saw that number, that's the middle bar, saw that number slightly lower, and people living in more institutional or intermediate care facilities, of course, had the lowest, but there are some extremely medically fragile people, and that's a little bit of a different story. And so in 2014, CMS issued the HCBS, Home and Community-Based Services Settings Rule. It required that services delivered to older adults and people with disabilities living in the community meet minimum standards for integration, for access to community life, for choice, for autonomy, for other important individual protections. The HCBS Settings Rule was heralded as a very important milestone. However, as we see from the trends here, obesity rates are higher for people that live in, especially for complex populations. Obesity rates are higher for those people that live in more integrated settings. So how do you have it both ways? How do you make sure that the spirit of the settings rule continues to be moving forward full steam, while also helping to provide options for people, of course, their choice for their health, welfare, and safety? And care management can play a helpful role here in helping people to move to more integrated settings. But they could also help to coordinate goals and supports around exercise, nutrition, healthy eating, medication management, to make sure that as people are living in the most integrated settings of their choice, they're also educated and have the tools available to make sure they're living healthy lives if that's the life they choose to live. So looking at the BMI was very helpful to understand in building models of care for complex populations. This is something to be aware of in those different models of care. And we take a look today at some of the financial outcomes. So again, the CMS settings rule we mentioned, the move to more integrated settings, as you can see from the graph here, of the 2,730 people, 1,371 live in non-certified settings today. Actually, hopefully the number is higher as people have the chance to move to more integrated settings. People living in certified residential settings was 1,149, and people in intermediate care facilities was 130 across the U.S. from this population. When we look at the difference between fee-for-service and for managed care, in a certified residential setting, that middle row, we find that the total cost of care for both the physical health care and the home and community-based services was about the same. However, what you find is that in managed care plans, they're often spending more on physical health care than in fee-for-service. Well, why is that? Well, as we saw, for example, the breast cancer screenings that we looked at earlier, if you don't go for your screenings, then the managed care plan is not paying for those screenings. If you don't go for your annual physicals, then the managed care plan is not, or the plan is not paying for those. And these are not exactly costs that the plan has a problem paying for, some of these preventative care and appropriate treatment, especially early. And so we actually do find that managed care does end up spending more on physical health care, but for the home and community-based services, we actually see some of those costs being less, specifically in a certified residential setting, where the costs are about the same, but 91% of the costs were for home and community-based services for fee-for-service, 71% of the costs in a managed care setting. And some of the reasons for that is there are many, but managed care also has the opportunity to identify both paid and unpaid supports, different church groups, volunteer opportunities, opportunities for its members to participate in the community and to receive services and supports that may not necessarily be funded as standard traditional services and supports. We see some really interesting and creative examples of ways that people are able to find employment and other opportunities. And again, it's not for everybody, but for a good number of people, certainly a population of almost 3,000, we start seeing some of these trends here. So does managed care save money for people that live in certified residential settings? Not really. In fact, it might even cost more. However, are those people receiving more physical health care benefits than well, not benefits? Are they taking advantage of the physical health care more than fee-for-service populations? Yes, they are. And one can hopefully extrapolate that through more preventative screenings and more treatment options for people, people should hopefully be able to live healthier and longer lives. And hopefully with care management and a more person-centered whole person approach, people should have the opportunity to live their best life and the life that they choose. In a non-certified setting, however, what we do find in managed care is significantly higher expenditures for the same reasons for physical health care, but the home and community-based services seem to be in a managed care setting significantly lower. So we did find for people in non-certified settings that managed care actually did both save money overall from the capitated rate, but also spend more on physical health care. In the intermediate care facility, we also identified that managed care did spend more. We also identified that somehow in a fee-for-service model in an ICF, that the fee-for-service model spent more on physical health care. This has a lot to do with understanding what an intermediate care facility is like, the nurses on staff, the extremely medically frail population, the fact that the sample wasn't that large either. So we're still trying to best understand what this means for ICFs in managed care. But the findings here is that the overall costs are lower in more integrated settings, almost by half, right? People that live in non-certified settings as a population level, the total cost is almost half of what it is for people in certified residential settings. And for people in certified residential settings, that total cost of care is almost half those in intermediate care facilities. Many people are in these settings because it's the setting they want to be in, and it's the right setting for that person. But when there are opportunities to help people move to more integrated settings because that's what they want, there's often a cost savings associated with it as well. And that's how we move the needle. So managed care does see the greatest cost savings for people living in the most integrated settings.
So before we wrap it up, we're going to do one more poll.
This is poll
What
number
are-
3. Go ahead, sorry.
Sorry. What are promising outcomes that result from a move from fee-for-service to managed care? Are they lower our overall costs, improved quality measures, better connection to the person's choice needs and their circles of support, or all of the above?
You still have time to answer. I'm getting a lot of great answers right now. Okay, last chance. Anybody else? Okay. I'm going to go ahead and close it.
Oh, very good. All of the above. Yes, absolutely. We agree. Wonderful. So to wrap it up, opportunities to improve outcomes for high acuity populations through managed care requirements. Managed care plans are uniquely situated to manage complex populations. They're able to see via claims what services individuals in complex populations are getting and what they're not getting when they're missing those previously scheduled appointments with their provider. You know, that's just as telling and just as important about what visits they are getting. By being a steward of the Medicaid dollar, plans are incentivized to arrange lower cost community-based services and interventions versus higher cost, less integrated settings. And managed care plans have care managers. Care managers are a vital part of a complex individual's care team. Nurses and social workers in these roles know all the ins and outs of healthcare systems. And most importantly, they're an extra set of clinical eyes, especially one who can see the whole picture, and they are key to whole person health.
Thanks, Heather. And I also want to thank Metascad's Data Stories team for help with this presentation, data outcome stories supporting complex high acuity populations by strengthening care management. Special thanks to Heather, Abby Rose, Matt, Rich, Rhiannon, and Linda. And with that, if there are any questions, we're ready for them. And if you'd like to reach out to us, feel free to email info@metascad.com.
Okay, it looks like we have some questions in the chat box or in the question box. So one was, you spoke about how moving people to more integrated settings can decrease costs. Can you explain a little bit more about how that process has worked?
Can probably take this one. So at an aggregate level, obviously the HCBS settings rule date is coming up. People are nervous about this because it changes where people live. People have lived in certain group homes or settings for years, and they're now sort of being told that they need to help people move to different types of settings, and it's change, and change usually makes people nervous. Typically, though, when you look at it, the costs for the services and supports are lower. What we've seen be successful with plans is through surveying and asking people, and these are conversations with the individual. Everybody is unique. There's no one size fits all for this. But when there are situations where people can live in in an apartment and they need some help finding that apartment, they may need some periodic supports in that apartment, they may be ready to move out of the group home. They may be interested in moving into a smaller group home. Educating people on their options is one of the most important parts, so that people know what's out there, what's for me, what's the right fit for me, because it should be my choice. And so typically through surveys and assessments, we can ask some of these questions consistently. The other side of that is the health, welfare, and safety. Can somebody be in a situation, do they have behavioral health needs that probably means that if the person's left alone for a long period of time because of their mental health, behavioral health, or if they have an intellectual developmental disability, or someone that's elderly with dementia, or some sort of a diagnosis, should this person be alone for a prolonged period of time. And that's helpful in understanding the level of supervision and the type of setting that's appropriate. And so an assessment tool that helps to ask these questions and identify people that are candidates because they say they want to live in a more integrated setting, and based on their needs and based on their supervision levels and their safety levels, they probably can and should live in a more integrated setting. This helps to find people that are good candidates. Telling someone that's really happy in the setting that they're in that you have to move because it's less expensive is not going to work for that individual or for their family. Many families and individuals are very happy with where they are. One of the other challenges that comes up a lot are families. The individual may want to live independently, live more independently, and they may have some family and circles of supports that may say that I'm concerned about their safety, and like for all of us, it's sort of their life to live. So these are delicate conversations, and the work that care managers do to have these conversations and to make these opportunities available, it starts with a data-driven approach. Well, for Medicaid, of course, everything starts with a data-driven approach. It probably doesn't for the care manager, but from Medicaid, the data-driven approach helps identify good candidates for people through assessment questions and their needs. And the rest of it is about relationships and conversations, educating people and listening to people to help people move to more integrated settings. So hopefully that answers the question.
Thanks, Doug. Another question was that you mentioned that one plan was able to get alternative breast cancer screening options approved. Can you explain how that worked and what the other options are?
Heather?
Yeah, so what Partners Health Plan was able to do was get sonograms approved. And I think part of the nature of it is that they had to be repeated sonograms over time. But they were able to petition the state of New York. And Doug, I think you actually worked with PHP quite a bit on this and have presented on it. So if you have any other specifics you want to jump in with, but in general, the quality measure was met simply because they were getting these women were getting repeated screenings, and the professionals were able to look at the tissue over time and say, yes, in fact, this is still healthy tissue, which is just wonderful.
Right. From those machines, I've never had one myself, full disclosure, but from those machines, they are large, intimidating, scary machines for people with sensory issues and for people with other behavioral and sensory needs. These are intimidating, they're scary. Also, people with physical needs, people that are quadriplegic, people that have people that have issues with ambulation, standing for these devices is just not an option for everybody. It's just physically not an option. And so Partners Health Plan was able to take that to their state's Department of Health, working with CMS in a really good partnership, and help explain to some very, very helpful folks on the policy side that this measure as written doesn't make sense for the population that we are supporting, and they were able to receive an exemption. Even without that exemption, their rates were still higher than national averages because the care managers make sure that for the people on their caseload, they have the tools to identify unmet needs, even without. However, there was a population that was not being reached for something as important as breast health, and we know from the data what happens if this preventative care is not factored into the person's overall health. And so fortunately, they were able to get an exception for sonograms, but even had they not, they still would have done it anyway. And their HEDIS measure still would have been pretty good anyway, but they were able to get credit for the great work they were doing.
Great, thanks, Doug and Heather. Well, I think that's all the questions that we had through the Q&A portion.
Okay, perfect. Well, I want to thank Doug and Heather, and you, of course, Linda, as well. That was a very informative presentation. It just goes to show the advantages of MCOs and being proactive with patients. I think that, you know, if you have to boil it down, that's one way you could describe it. So thank you both very much for that presentation. I want to remind our attendees that the Metasced team will be in Phoenix in September for MHPA 22. They're exhibiting, so you can go and meet them. I recommend that you do so. They're excellent partners with MHPA and do great work with our members. So I want to thank everyone for attending today, as well as Doug and Heather, and I wish you all a great afternoon.
Thank you very much.
Thank you, everyone. Thank you, Patrick.
Have a good one all. Thank you.
Thank you.